So why ankle fractures are so special? Because they are second most common fascial injuries, constituting about 50%, 58% of distal tibial injuries are sports injuries. And this physis is less tolerant or forgiving. And a slight amount of deformity can really give you a degenerative arthritis. And as we are trying to assess that why how can we prevent the fascial arrest in ankle, we can divide those factors into two categories, one which you can't modify or control, that's age at injury, mechanism of injury, fracture pattern and fracture displacement. Let's understand now further. And someone which you can really control to some extent, whether it's a closed reduction or open reduction, attempts of reduction, quality of reduction and implant placement. The age at injury. Distal tibial physis grows as fast as the proximal one till 10 years and thereafter decreases significantly in adolescence. So earlier the injury, higher chances of deformity due to growth arrest. Whereas the TLAW and the triplane injuries, they occur during adolescence, so they have less chances of fascial arrest. Understanding about the mechanism of injury, as per this paper, higher likelihood of growth arrest is there with high energy injuries versus low energy injuries. Understanding about the fracture pattern, the type 2s and the type 3-4s, they are more prone because they are involving the physis directly. We follow the Diastaggian classification. It gives the treatment insights because it follows the injury pattern. But out of this classification, the supination inversion is more common and is more prone to have fascial arrest. Regarding the fracture displacement, there is not a proven correlation, but various studies have shown the trends of increasing incidence of fascial arrest as compared to non-displaced fractures. And if the initial displacement is more than 6 millimeter, the chances increase by 9 times. Open versus closed reduction, the cumulative evidence at present does not indicate an association between the method of treatment. Both treatments are feasible, but the less surgical related complications are associated with closed treatment. And regarding the attempts to reduction, there is a definite increase in fascial arrest chances if the number of attempts of reduction are for more than 2. If you try it multiple times, the chance can go up to 50%. Regarding the residual displacement post reduction, if you have a gap which is more than 3 millimeter, then the chances are more than 60%. If there is a no gap if there is no gap at all, but still the chances can be till 17%. And you have this gap which is more than 3 millimeter, then you should raise the suspicion of entrapped periosteum. That will increase the risk, and in such situations you may have to resort to open reductions. Now surgeon have definitely control about the implant placement. The preferred implant is a 4 millimeter cancellous screw. It should not cross physis. Try to avoid washer and aim for the articular congruity. If at all you want to use a K-wire, it should be smooth, non-threaded, size should be 2 millimeter. Try to aim in the center, avoid multiple attempts, use a low torque drill, and if you use a K-wire, you time it, remove early. And ensure them to have a good follow-up of at least 2 years. So the take-home message is, you classify the fracture pattern, reduce the minimum of attempts to minimum, ensure that you don't have a gap which is less than 3 millimeter, and respect the physis while putting up the implant, and ensure an adequate follow-up. Thank you.